You'll tell me when it starts?
We're going to cue you. We have 2 minutes.
Oh, okay.
Throw that.
Oh, I like that. Yeah.
So straight. I know some. Maybe horizontal straight. It's not the greatest idea.
Do you think if we go long, they'll time us, like tell us to stop? I don't think I'll go long, but
Yeah, who's gonna tell us? I think they'll tell you. He
John,
has.
you're all set? Yep.
He does have the cue, so maybe behind the camera.
yeah.
Maybe Dr. De Silva? No?
You're live.
You're live.
Ah. Should I start? Good afternoon and welcome to the World Prurigo Day. My name is Gil Josipovich. I'm a professor of dermatology and director of the Miami Edge Center at the Dr. Philip Frost Department of Dermatology at the University of Miami. I'm also the president of the National Edge Foundation. This is a new foundation that is dedicated to advance the field of itch. I would like to acknowledge the gracious support of Regeneron, Sanofi, and Galderma for this Prurigo Day event and their commitment, both companies, to advance the field of research, education, and innovation in the field of prurigo nodularis. And I'd like to thank my outstanding faculty and especially to our courageous patients here that are going to share their experiences and their story of prurigo. This will also enable you to understand the significance of this disease. Prurigo is not just a disease of itch that is mild. It's a disease that has a significant impact on the quality of life of patients and on their life, whether it is effect on their sleep, their relationships with other people, their work. And this is a disease that until recently was not well treated. But this is actually a new era. In the last several years, there are new developments of drugs that are targeting this disease, and a big hope for our patients that this disease is treatable. And really what we are trying today to explain to many of our colleagues, the audience includes not just patients, but also caretakers, physicians, pharma researchers, and other stakeholders, is that there is hope, and the message here is to be aware of this important disease. This event of the Prurigo Day is not just about science and research, it's about people, because the story of prurigo nodularis and the experience of these patients really help us to better understand the suffering of chronic itch. Prurigo nodularis is one of the most extreme types of chronic itch that patients suffer. So again, I want to thank all of you for attending this event, and without further ado, I would like to start with our first speaker, Dr. Sufi Chen. Dr. Sufi Chena is a former chair of dermatology at Duke and now is a professor in Jefferson in Philadelphia. And she will discuss why prurigo nodularis matters. She's a world expert in epidemiology of itch and quality of life. So, Sufi, it's all yours.
So first I want to ask everybody to really embrace this moment. This World Prurigo Day is really quite something special, to really celebrate this around the world. I'd like to thank Gil for giving me the opportunity to kick off with our first talk. So my charge is to explain what living with prurigo nodularis is like, the scope and the burden. These are my disclosures. I do develop quality of life instruments, and there are some that are relevant today, the ItchyQual and the SDOM. So I think it's helpful to understand the evolution of understanding prurigo nodularis. When I was training, we didn't know about it like this. So we know that people itch terribly, and we could go down one of two pathways. Either scratching and rubbing, especially with large areas, or with picking or scratching particularly small areas. And how one goes down one path as opposed to another, that's still something that we need to discover. Now, either pathway that we go down, people get caught up in this itch-scratch cycle or an itch-pick cycle. And it goes round and round because as you scratch or you pick, the skin becomes more broken and it becomes more inflamed and more uncomfortable. And so then it becomes this vicious cycle until you get down to the bottom there where you either have really large plaques or you have these nodules. So recently, we've tried to decide whether or not prurigo nodularis is considered a primary disease or a secondary disease. Secondary means that it comes about because something came first. In the secondary diseases, we have well-known dermatitis, atopic dermatitis, contact dermatitis, that have known inflammatory mediators. These cause people to really be itchy, and then they go down the line of scratching and picking that gives more mechanical injury, increasing nerve fiber density, and then that cycle that I was just talking about, more and more itchy, and developing these nodules. And so, these are hard nodules that itch. But some people don't start with a rash. They become itchy, and we think that there is some dysregulation in the immune or the nerve system. And again, these inflammatory mediators are released, and it goes down that same cycle, now becoming something called prurigo nodularis. So this is now a specific diagnosis as opposed to using that umbrella term of prurigo. So how does it all start to eventually become this prurigo nodularis? We've now put names to this. The CPUO, or chronic pruritus of unknown origin, may have dysregulation in the immune system and abnormal firing of the nerve pathway. And so that's why some of the medications that modulate the nerves seem to work better in this population as opposed to the ones that started off with a rash. So this paradigm of thinking is actually fairly new. Now, to understand how much this is impacting people, I want to rely on this one great review paper that summarized things together. This is the scope for the worldwide prevalence or incidence. You can see that it's well studied in the United States. All those bars are the different studies that have been published. It's not quite as well studied in other parts of the world. You can see in Europe there's a little bit, Japan and Korea. You can see that there's a big prevalence in the United States, and maybe less so in the other country, but I'd submit to you that maybe we just haven't studied it enough. In the United States, we've looked at racial disparities. If you look at that graph on the bottom left there, the blue bars represent Black or African Americans, whereas the red bars represent white Americans. And for almost every skin disease, atopic dermatitis, psoriasis, it is white people that get affected more. But on the very left-hand side, you can see actually for prurigo nodularis, Blacks tend to have more than white. So why is this? Maybe something related to the social determinants of health, maybe something in the skin. This is something that we need to look further into. People will ask, well, what about Asians? Well, this study was done in Baltimore, which really doesn't have very many Asians. And so I pulled a paper that was done in Korea. And you can see that there actually is a lot going on in Korea. It seems to be higher in men as opposed to women. But what I think is really interesting is on the upper left-hand corner, the disease seems to have jumped from 2014 up to 2020. And that may be because we became more aware of it. So we know what to call it with that kind of diagnosis. So pivoting over to quality of life, this really affects people's lives. Sleep disturbance was the most big thing that people complained about. But it also affects daily life activities such as social activities, relationships, needing to skip out from work and school because you're just too uncomfortable. When asked about symptoms, obviously itch is the biggest one, pruritus, but also the fact that the skin lesions are visible was a big deal, and then bleeding from the skin lesions from the scratching and the picking that people are compelled to do. There's a lot of psychological comorbidities, very, very anxiety-provoking, causing a lot of depression, a fair number of people having thoughts of suicide. There are other psychological morbidities that come with having a prurigo, eating disorders, self-harm, attention deficit hyperactivity disorder, schizophrenia, mood disorder. Not that it would cause these, but it definitely seems to run together. And looking at other disease burden is the economic analysis. So this one particular study used a tool called the HUI-3, or the Health Utilities Index Mark III, and they were able to incorporate the quality of life impact with the amount of life years that were expected from this cohort of patients. And doing the economic analysis, what they found is that in an individual lifetime, this has an economic burden of over $300,000. If you extrapolate that to society, to the United States, that's almost $40 billion. So this is not a trivial disease burden. Now, how does one quantify quality of life burden? Us researchers will have self-reported itch severity using various different scales. We also have quality of life instruments. The Dermatology Life Quality Index is the common one. Those people going on trials have become familiar with that. And then the ItchyQual is another one. These are the scales that are commonly used. They either have cartoon annotation, like with the ItchyQuant, or they may be a line or numbers with boxes. And we can interpret these scores with how itchy one might be. This is a snapshot of the Dermatology Life Quality Index, again, producing a score that can tell us how much of an effect on quality of life there might be. And then the ItchyQual, very similar, but this has 3 different constructs that affect people's quality of life who are itchy. And again, we have understanding of what these scores mean. So again, going back to the literature, it seems like using these tools, people with prurigo nodularis have moderate to severe, very itch severity, very large effect, or at least a moderate effect on quality of life. Tools that people can use in clinical practice. So for those of you who don't necessarily do research, but definitely take care of patients, there are tools that you can use in your 15-minute visit to really understand what your patient might be going through. This is an instrument that our group has developed. It's the standard dermatology outcome measure. It has that ItchyQuant to get an itch score. It has a global measure of 3 quality of life measures. asking people whether or not they're clear all the way up to severely affected, whether their problem is good enough, or whether or not they want to keep pushing on as far as different therapies, and then whether or not they had side effects. This is something that takes at most 3 minutes to complete. At Duke, we actually gave these ahead of time so that patients could complete them on the portal, and over 50% of people completed them without any reminders. So this is definitely quite feasible, and I personally use this as a vital sign. I have this in front of me when I walk into the room so I can see how to set the agenda for that particular visit. If their itch score is super high, that's definitely something that we're talking about. If they're emotionally impacted, that's going to be on the agenda too. Just focusing on particular questions within the SDOM. I just want to conclude that prurigo nodularis is increasingly recognized as a primary diagnosis, and that's what today is all about, is really to increase that awareness. We definitely have to do more research on the scope and burden of prurigo nodularis, including racial disparities, how quality of life is affected, and even more on the economic burden. Thank you very much for your attention.
Thank you, Sufi. Our next speaker is Lee Natkemper. Lee Natkemper is a researcher, a neuroscientist that has been is an associate professor at the University of Miami, working with me, and has advanced significantly our understanding of prurigo nodularis with her basic research, as well as she's in charge of all the clinical trials that you hear about, the use of biologics and other drugs for prurigo nodularis. So, Lee, please.
Well, thank you so much for letting me talk today. I'm going to let you guys know that my job today is kind of get you to know the mechanism behind prurigo nodularis. Why is this happening? And a lot of times, a lot of the patients that I see as part of the clinical trials at the University of Miami, they'll come and be like, why is this happening to me? Why am I feeling this itch, or why am I always feeling the lesion coming up before I even, see anything on my skin? So I'm going to start with this big picture. The big picture is that prurigo nodularis is a neuroimmune disorder where immune cells and sensory nerves within your skin are overstimulating each other. There's big sensory feedback loop that just keeps propagating one another. So there is this neural dysfunction that over time your nerves become hyperactive within the skin themselves, and that actually leads to changes in your spinal cord and the brain itself. So you have a hyperactive nervous system that can propagate this signaling. So this willing to pick, this willing to itch, to create and kind of induce more of those lesions. So the small picture is in the skin itself. These are the different types of lesions that you can see. It starts with this tissue remodeling. So we start with these little small papules. If you keep itching, keep scratching, they get a little bigger into nodules, they progress into plaques. More people who keep scratching, you can actually ulcerate these lesions, you can see the scratch marks. And then when we do get to actually treat them, we actually have scars still showing on the skin. So this disease, even with treatment, is still visible on our patients sometimes, even if they have no lesions, still have no itch. So where's this small picture coming from? And it's coming from a few different things. It's the thickening of the skin. This is where you're getting all these different lesions from. You're actually getting a reduced nerve fiber innervation within the top layers of your skin, which seems counterintuitive. You would think reduced nerves would lead to less symptoms. But remember, that big picture, I said that you're oversensitive. So your nerves are overactive. So less nerves overactive is propagating that more itch. And because if you have those overactive nerves, those immune cells that are coming into that location are keep activating, keep looping that pathway. And I'm going to try to kind of bring you through some of these really complicated figures that us scientists, we like to put together. But patients get a little bit confused. They're like, what is exactly going on in my skin? So we call this a local neuroimmune crosstalk. There's where these different type of immune cells come into your skin. These type of cells, we call them things, you're going to hear all these terms like T cells, these are lymphocytes, mast cells, eosinophils, basophils, macrophages, different type of inflammatory mediators are going to come localized into the area of the lesion. They're going to interact with those nerve fibers that innervate the upper layer of your skin, and they're going to cause this loop of itch and inflammation. So I'm going to kind of get into what some of these loops are. And bear with me, I do not have a pointer, so I'm going to try to talk through some of these really heavy figures for everybody. So we're going to talk about the one thing everybody talks about when you think about prurigo nodularis and its mechanism. Where is this coming from? Everybody you hear is going to hear about Th2. This is a Th2 immune disease. What does that mean? Well, this is these T cells, these lymphocytes are a type of cell, helper T cells, that come into the skin, and they actually release these chemical messengers, these things that we call cytokines. These cytokines will activate and alert all these other cells. So once again, this loop just keeps getting propagated. So these specific Th2 lymphocytes will release things like IL-4, IL-13, IL-31. These are the cytokines that you're going to hear very common that are involved in prurigo nodularis. So these type of cytokines, you can kind of see here my little red circle of the T cells listing all these wonderful little IL, these cytokines, recruiting more, dealing with others type of skin cells, and then going back to those nerves to sensitize that nerve, to make those nerves hyperactive. So in PN itself, you actually get that modulating expression of more of these cytokines than you actually should. So because of that, we actually get more cytokines, we get more receptors on different cell types and of these nerves. So more signaling is happening, more sensitization of those nerve fibers, and then it causes your skin to change itself, bringing in specific cell types like fibrotic tissues to actually change and make more of that thickening skin lesion that I showed you in those first two types. So why is talking about these T cells and these type of cytokines important? Well, it's because if you come into clinic and you get treated, which another faculty is going to talk further about some of the treatments in prurigo nodularis, but it's important to understand these cytokine mechanisms in these T cells because right now, our two FDA-approved treatments for prurigo nodularis, these biologics, target two of these cytokine messengers or their receptors. So you can kind of see this is weird little wonderful nerve ending with our different cytokines coming in, and all these little blue boxes are new drugs that are either in testing in clinical trials or FDA approved for treatment in prurigo nodularis. So you can kind of see where in the scheme of this mechanism we're finding out what is happening in prurigo nodularis and how we can stop it. So is there one target we can stop? No, but we're pretty good at getting some of these other targets to stop and hopefully stop that cycle of the immune and that neural overactivation. Another cell type that you hear when you talk about inflammation that activates nerve fibers within these in your skin are mast cells. These are things that we talk about even in acute itch. When you get that mosquito bite, your mast cells are the ones that are going to release histamine and cause you to have that itchy bump. When you scratch yourself and causes your skin to raise up, those are those wonderful mast cells releasing that histamine. In PN, these mast cells also become overactivated. And just like those T cells I mentioned before, they can sustain other immune cells by releasing these messengers. They can cause more messengers to come to the area, and then they can also sensitize those nerves. So once again, this is just another loop in this disease that we're finding of these immune cells sensitizing nerves, causing this overreaction of nerves to cause itch and even pain. So in summary, like I said, us scientists, we like to get a little bit complicated down here. So there's a lot going on. There is not one answer to this problem. We have a lot of mechanisms that we do get to look into and we do need to further discover more. But we are understanding that there are more cycles, that there is a dermal inflammatory cycle that affects skin nerves that then go to affect your spinal cord and your brain. And this all gets propagated by scratching the lesions themselves. So this feedback loop is also effective. Thank you.
Thank you, Lee. Our next part is maybe the most exciting and is what we need to listen very carefully is the patient's perspective and experience. So I'd like to call the first patient. We'll have two patients today, Catherine McCoy Lewis, who will share her personal history and her experience going through her PN disease. So Catherine, please.
Thank you so much. Thank you for having me here today. And I've already learned so much about this, so it's a great experience for me to be here. My experience started in September 2025 when I started scratching, which was nothing new to me because I have very sensitive skin. I itch a lot, but I've never itched like this before. This was really bad. And the first doctor I went to, it started on the side of my stomach around to my back, and that doctor thought it was shingles because of the one-sided pattern. I'd already had the vaccine, but the doctor said that didn't necessarily rule it out and put me on prednisone. And I'd always said prednisone was my drug of choice because when I had sun poisoning or reaction to insect bites, that always cleared it up right away. And this time it did nothing. So then the diagnosis was, because by now it was spreading all over my stomach, my back, my lower back, and the doctor thought it was very dry skin. So I had topical steroids. I had every moisturizer you could think of. I could have slid across the floor. I was so greasy by that point, and it did nothing. And the only thing that helped at that point, ironically, was Advil. And I guess because Advil is an anti-inflammatory. And by then I was taking copious amounts of Advil, which I was told was a really bad idea. But I said at that point it was going to be Advil or heroin, and since Advil was more readily available, I was going with Advil. But eventually we were able to make the switch over to gabapentin, which actually helped a lot and reduced the Advil. The only other thing that helped was ice, and when I was home at night, that was great because I could move the ice around, but when I was out, you can't travel with an ice bucket, so that was not an option for going about during the day. By then, I was going to all different doctors. Everybody was warning me, don't scratch, because they explained the itch-scratch cycle and how that would make it worse. But I said, telling somebody not to scratch is like telling somebody having a panic attack to just calm down. It's not going to work. I couldn't help but scratch, even if it was making it worse. And they asked all the questions. Did you change medications or detergents or soaps or food? And it was no to everything. There had been no changes. Although my son, my 25-year-old son, Alex, said, well, there was one change in September. I moved back home. And I thought, aha, yes, he did. And even though I was thrilled to have him back home, those first few months were very stressful. So who knows if there was a connection there or not. But I went through all the blood work to see if it was liver, kidney. All the blood work came out fine. And it was really exasperating because there were no answers, and the itching continued. And then my sleep started to be affected. I went through about 5 or 6 weeks where every night I woke up at 2 or 3 a.m. just scratching. I would take whatever I was taking at the time. Benadryl or hydroxine was effective, but took a while to kick in. And I listened to a lot of great books on tape during that time because I would be up every night for about 2 hours. My dog wasn't happy. My dog would be up with me. It was such a horrible experience to go through that. And then the rest of the day, you're never, fully there because you're exhausted. My pattern was I would wake up and scratch that first hour a lot, take Advil, gabapentin, whatever I had, and I'd actually be okay through a lot of the day. But then the fear would start because I knew in the late afternoon, early evening is when the itch was really going to kick in and I'd be off to the races. And during that time, I was teaching a course one night a week, and I was traumatized because I would be teaching and talking and trying to scratch surreptitiously. I'd be running to the ladies' room to put on moisturizer, and it was both mentally and physically really horrible. Physically because of the itch, and mentally because you knew what was coming and you knew you couldn't do anything about it. And it was just exasperating. Doctors tried. One doctor said it was scabies. And I thought, you know, I have an English degree, not a medical degree. I don't think it's scabies, but I did the treatment anyway. Nothing changed. One friend kept saying it was bed bugs. So I did everything. I stripped the bed, I got the flashlight, I read that no, you needed a UV light, I got that. You know, I couldn't find a bug anywhere. I tripled my antihistamines, that didn't do anything. I was using every lotion and soap and detergent that was sensitive free, nothing added, nothing seemed to make a difference. Then one friend helpfully sent me an article in the Wall Street Journal about a woman who had gone through everything I had gone through for 2 years, and it turned out to be Hodgkin's lymphoma. So that was a fun few days, wondering if that was the issue. My internist said that, you know, all my blood levels were fine. There was no indication of that. We did a chest x-ray just to make sure that, thank God, was fine. And then finally, I found a great doctor who you're going to hear from today, Dr. Nadelman, who said, we're going to get to the bottom of this and we're going to find out what the issue is. And she did a biopsy. And it was a long wait of 2 weeks for the results, but that's when we found out what we were dealing with. And her suggestion at the time was Dupixent and phototherapy. And I vividly remember driving home that day and calling my insurance company at the time about the Dupixent and having her say, oh, we don't cover that. And I just pulled over to the side of the road and burst into tears because I thought, finally, after 6 months, I thought I had an answer, and they said, no, we couldn't do it. Dr. Nadelman said, don't worry, we're going to try Ebiglyss. And I did do the phototherapy just 3 times because driving downtown, it was a 30, 40-minute drive. Parking was another 15 minutes. Waiting for the appointment. I was only in there for a minute, but everything around it took so long that I only ended up doing 3 of those. But then I did my first shot of Ebiglyss, and knock wood, thank you God, it worked. And I was very fortunate because everything I read said it could take a while to work, it might not work, there could be side effects. And, you know, again, fortunately, that was in March. Now we're in June. It's been great. I do still get twinges. You know, every couple of days, my itching had moved to my thighs, and I'll get a twinge in the thigh. I'll take a gabapentin and I'll be okay. And I don't know if that's psychological or what, but I'm not questioning it. It works, and it's just been so much better. And, you know, just talking about it, I think I'm getting flashbacks. I think I have PSTD from it because I have both emotional scars and physical scars. You saw the slides with the scars. I scratched so much that they're still scars. You know, at the time it was so bad. I said, you know, I couldn't go to a swimming pool because I would empty the pool once they saw me coming out. Most of that has faded, but there's still scars from it. And just mentally, you think people were very sympathetic, but nobody, I think, if you haven't gone through it, can understand how it takes over your life, not just physically, but emotionally, because you're so worried, when is it going to start? How am I going to be able to control it? And your life kind of shrinks down to that one phrase, like, make it stop. Please just make it stop. In the middle of it, I thought it was never going to end. I am so happy that it did. I would tell anybody going through it just to keep the faith, to keep trying, to research, to do everything you can to find exactly the right doctor, because for me that made all the difference. Find the right medication if you have to argue and fight on that. Even now, I know that if, God forbid, this stops working or I have side effects, I have read everything that you've written about, things on the website that tells me there are other medications to try. Now I have a doctor who I know is aware of that and will fight for it. And just keep the faith to know that eventually more will be revealed and there is light at the end of the tunnel. It can be a very itchy tunnel, but there is an end to it. So thank you so much for the chance to be here today.
Thank you, Catherine. We will have later on questions, and I'm quite sure there will be a lot of discussion. And I'd like now to call my patient, Cheyenne Boulet. Cheyenne is been also in clinical trials, and Cheyenne, I will ask you some questions about your experience and the toll that prurigo nodularis had on your life. So thank you, Cheyenne.
Hi, I'm Cheyenne. Just listening to her speak and talk about it, it made me emotional because I feel the same way. Like it's a very, sorry, I have to calm down. Sorry. It's a very big part of your life, and you don't know how much it's gonna affect you till it happens to you. So yeah, so okay. I'm done. But yes, I'm Cheyenne. I also have prurigo nodularis. I'm from Miami, Florida, and I'm also 26 years old. So I've also had this since 2018. I think that's when it started, and I was about 18 years old, and I was just coming from high school, and I was freshly graduated, and then, you know, I felt something happen, and I thought it was eczema too. I thought it was, I don't know what I thought it was. I just thought this cannot actually be eczema, because eczema does not feel like this, and I understand that I've also had a lot of skin problems too in my past, or like when I was a kid I had eczema. So I was like, you know, maybe this is like something small, or this is not as bad as I think it's gonna be, or, you know, it's just something that is gonna happen and the dermatologist is gonna fix it and everything's fine. But that's not the story. But yeah, so I'm gonna ask you questions, or should I just keep
Yeah,
going?
sure.
I don't know.
Want to kind of elaborate what was the most severe aspects of the disease and
Okay.
how it affected also your interactions with other members of your family?
Right. Okay. Well, okay, so to harp on that or summarize that, as it started in, you know, 2018 and I was graduated, I had to, you know, tell my mom, you know, Mom, hey, I had to call my mom. She was the first person I called, that, you know, maybe I have eczema, or like this is something that I just don't understand yet. So can you take me to the doctor? Can you call the doctor? Because I'm freshly graduated. I don't know. I don't usually call my own doctor. So I was like, you know what? Please, Mom, help. Like, this is actually very serious. So I went to the dermatologist. They also told me like I had scabies or like bed bugs, or like just, this is something, yeah, like I have scabies and bed bugs. But I'm like, no, I don't. I don't have bed bugs. Like that can't be true. But I still went with the treatment. They said I had scabies. Like I've never even heard that before till that day, for real. So I was like, okay, like I guess I'll try the topical creams that they gave me. It didn't work. And I noticed that I understood that it was more than eczema when I just started scratching so much, and like it took me like an hour to scratch, and then like I would still have to scratch, so there'd be another hour that goes by, then I'm bleeding. And I remember one time I scratched so hard that like I couldn't put my hand like this. It was getting stuck. That's how bad I was scratching, now that I'm remembering. And it just feels like something that you can't satisfy, or like even as I'm scratching, or like as I'm thinking about it, I scratched for like maybe 2 hours that day, and it felt like the pain was terrible after, but even as I was doing it, it was like pleasure. Like I was like, wow, this is very satisfying. Like, you know, when you have an itch and you really have to scratch it and you're like, oh yes, finally I got that itch. It would be like, yes, I finally got that itch, but now like there's another itch somewhere else on maybe it started on the bottom of my calf, and then it started going up to my knees, and then it started going up to like my thigh, and then that's when it started going to my arms. And I'm like, okay, this is actually really terrible. And I remember I couldn't go in the shower. Like from me scratching so hard and me bleeding after me scratching, like I couldn't go into the shower. I remember that I had to also carry like cold water everywhere, or I would have to like carry ice too. Like I would bring my lunchbox, carry like a cold pack of ice, or even as I'm driving on the street, like I would have to like scratch. Like it would like be so bad that I would have to scratch even as I'm driving. and I was almost crashed one day, and I was like, okay, this is really bad. I need someone to like figure it out because I'm suffering. So yeah, sorry. I don't know what I'm supposed to say. Go ahead. Your next question, or
Okay.
yeah.
Why is the Parago Day important for you?
Why is Parago Day important? I believe that Parago Day is important because of the fact that it just brings more awareness to other people who also have this. Because as she was talking, as Catherine was talking, it was just like I started crying because it just brought more awareness to me that I'm not alone, you know? There's also other people in this who has gone through the same things. We may not be the same age, we may not look alike, but I know exactly what she's talking about. And I feel like just having that other person there, having like, you know, those other people to understand like you've gone through the same thing that they have, it's very touching. It's very like, you know, I just want to make sure like I get to know you more. I want to make sure like I'm broadcasting this to other people who maybe they don't know what it is, or maybe they're trying to figure it out right now. Or it's just like she said, like it just helps me understand that there's like I have faith, like I understand that things are going to turn around, and the fact that this has been broadcasted, or like the fact that it's here now and we know kind of what it is, we're still trying to find the answers, and there's also doctors to support us in this, you know, it's very touching. It's very like, wow, like everything's going to be okay. I think I feel like I have more faith now that everything is going to be okay. And even if in the back of my mind I'm like, I don't know when this is going to end, I don't know if this is curable, I'm understanding more that this is my life now, and that I just have to, you know, I just have to deal with it also, and also know that there's people here for me, here for, you know, all of us who have PN, you know. Yes. So, yeah.
Can you tell us about how the treatment changed your life?
Oh, yes. Wow. The treatment, oh my gosh. I feel like when I first started getting treatment, actually, and I went to clinical trials now, and this is I went through a clinical trial through, you know, Dr. Gil Josipovich, and he also led me to Dr. Nat Camper, and they've been like such a great support. Like, even the fact that I was in the clinical trial and it could have been like, you know, no money, I wouldn't have done that for any money. They said that I would be getting funds, and I was like, wow, this is great. I would do this for $0. Like, thank you so much. Even as I was going through the trial, or even the fact that there was like a placebo at first, it gave me so much hope. I feel like it made me itch less because I was like, I am so hopeful. But when I actually got the medicine, I was like, okay, this is the stuff. This is great. Let's keep it going. So I was like, I don't know, like they're supporting me, and I just felt like there was a light at the end of the tunnel, like she said. Like, I truly feel like that. Like, right when I got it, I was like, wow. And now, like, I'm actually taking, you know, I took Dupixent now, and then Nemluvio. Dupixent was great because I'm like, okay, I'm itching so much less. I finally like could start wearing clothes, like I could wear shorts now instead of wearing like long skirts, or like trying to wear long sleeve shirts. And especially because I live in Miami, Florida, that's actually impossible. So people are gonna have to see how my skin looks, and it just gave me more confidence to live my life, I guess, before this, or before I had PN, and not worry about who's looking at my skin, or like how someone's gonna feel when I'm next to them, or if they're gonna think I have a contagious skin disease, because I've gotten that before as well. And it's just really, it gives you hope. It's like, yes, like I can actually live my life and like not itch all the time, or not have to worry about waking up in the morning and like there's blood all over my bed, or there's blood all over my clothes, or I have to clean myself up, or like take the bed sheets off and wash it every day or every 2 days. It just gives you faith that everything is gonna be okay. Like, and I don't have to itch as bad, like, or I don't have to, or even the fact that I don't know like how long this medicine is going to be here for, or, like, you know, insurances and everything. That's always in the back of my mind, but it's just the fact that I'm not itching as much right now. Right now is the present, and I'm in the present, and that's all that I can hope for. So yeah.
Well, thank you.
Yes,
Cheyenne.
thank you. Thank you for having me. Thank you. Okay.
Our next speaker is the doctor of Dr. or Katrine, Emily Nadelman. She's a professor in GW, and she will discuss of recognizing prurigo nodularis, the clinical practice and diagnosis, and the comorbidities. So, Emily, please.
Great, thank you so much for having me. My name is Emily Nadelman. I'm a dermatologist at GW and the University of Maryland School of Medicine, and I'm very excited to be here today to talk about how we diagnose prurigo nodularis, how we can recognize it, why it's important, how we measure its severity, and also how we recognize comorbidities as well. So here are the learning objectives. We're going to recognize the core clinical triad that defines PN, apply a structured diagnostic workup to identify PN and rule out mimics, use a validated severity tool to stage disease and track response, and we're going to screen for the comorbidity web that shapes PN outcomes. So why does prurigo nodularis matter? There is a huge diagnostic gap. It takes an average of 4.5 years to diagnose this condition. That's 4.5 years that these patients are suffering. And this is from a recent 2025 paper which included almost 100 patients. And you know, as we've heard many times today, prurigo nodularis is frequently underdiagnosed, but it does affect like close to 100,000 patients in the United States. And once it's established, it's an independent disease that needs its own diagnosis algorithm and its own treatment options. And why it's important that we're here today is because we need to close this gap of 4.5 years. As clinicians, we need to help others recognize this disease. And as patients, it's really important to advocate for yourself if you think you have this disease. So how do we define prurigo nodularis? So the European Dermatology Task Force and the US Consensus Task Force defined it with 3 criteria. 1 are pruriginous or itchy lesions. These are hyperkeratotic or crusted. They can be excoriated or like scratched at, papules or nodules or plaques, and so they can range in size from millimeters to 2 to 3 centimeters, and we'll look at some pictures in the next slide. You also need chronic pruritus, which is itch, for greater than or equal to 6 weeks. And this prurigo nodularis has the highest itch intensity of any dermatologic disease. And third, you need this itch scratch cycle that we've also heard about today, where you have this history of like mechanical disruption of the skin, where you're scratching, picking, and rubbing. Sorry. So there are 5 defined clinical subtypes of PN, but I'm sure there's more than this as well. So there's the papular subtype, which are 1 to 3, or like less than 1 to 3 millimeters, and you can see these like pink papules. Nodular subtype, which are like 1 to 3 centimeter, these raised plaques that are hyperkeratotic. Plaques, which are greater than 1 centimeter, that are like these very thickened areas of skin. Umbilicated, where you see this like central indentation or umbilication, and then linear, where you actually can like follow the lines of scratching. But oftentimes patients have all of these subtypes at once. They can switch from having a papular subtype to a nodular subtype, but the nodular subtype is the most common. Okay, so this is just an exercise, and so you know, we're going to go through the answers of which one is prurigo nodularis, but looking at A, B, and C, which do you think is prurigo nodularis and which features help you decide? I'll give like 5 seconds. So B is prurigo nodularis, and you could see these hyperkeratotic nodules that are on an extensor surface with like a central excoriation. A is nodular scabies mimicking arthropod bites, and C is hypertrophic lichen planus, which we'll talk about a bit on the next slide. So what should we be looking for in a patient with prurigo nodularis? So these patients can have a few to hundreds of lesions, as I said already, from few millimeters to 2 to 3 centimeters. And typically the lesions are symmetric, affecting the extensor arms, legs, trunk. And there's something called the butterfly sign, where they spare the mid-back where patients can't reach. And it can spare the face and the palms. And we can see in lighter skin, it's light red to bright red and pink. In darker skin, it's more hyperpigmented, violaceous, and densely fibrotic. And then we can also see secondary changes like excoriations, scratch marks, erosions when the skin's open, and it can actually become infected, crusting, lichenification where it's very thick and looks rubbed, scarring, and dyspigmentation. And then we use our dermatoscopes as dermatologists, which are like magnifying glasses, and we can see this white starburst pattern that you see in B that can also help us at the bedside. So I just showed hypertrophic lichen planus and nodular scabies, but there's many conditions that can mimic prurigo nodularis, and we heard from our patients that they were told they had scabies, they were told they had bed bugs, but there's key distinguishing features as clinicians and as patients that can help distinguish these. So lichen planus is more violaceous or purple, and the hypertrophic type favors just the shins. Nodular scabies in general tends to favor like the skin folds between the fingers, under the arms, and they have burrows, and frequently like close contacts are also affected. There's also a condition called pemphigoid nodularis, which it looks exactly the same as prurigo nodularis, but you can also see blisters, and you could distinguish this by doing a biopsy, and you would have a positive DIF, which is an immunofluorescence test. You can also see skin cancers that look similarly, cutaneous T-cell lymphoma. In patients with a history of chronic kidney disease, you could see something called a perforating dermatosis and bug bites. But when in doubt, you should biopsy, and that's just what I did for our patient that you heard from today. So I won't get too into this, but on histopathology, there's some key features that you see. So hyperkeratosis, or like thickening of the skin, irregular acanthosis, where you just see like thickened areas of the epidermis, which you can see on the top. You'll also see fibrosis, because this is a fibrotic disease, and then we see increased nerve fibers and increased immune cells, like mast cells that we heard about already. And then I won't get too much into the molecular pathology, but there's been so much research, including something called single-cell RNA sequencing, where we're actually looking at like each cell type and which cell types are upregulated and which immune pathways are upregulated. And we see that fibrosis is the main distinguishing feature between prurigo nodularis and atopic dermatitis. And we also see like neuroimmune uptake as well. So there's actually two different subtypes of prurigo nodularis, an atopic type and a non-atopic type. The atopic type is, in patients who have a history of eczema, allergies, or asthma. This affects 20% of patients that are more female and more Black, and it has its own associated comorbidities. And then there's a non-atopic type, which affects 80% of patients, and it could be associated with kidney disease or renal disease. But a key takeaway is that these are treated the same. They both respond to the same medications like dupilumab and nemolizumab as well. So a patient comes into your clinic. How are we going to work them up? So first, we're going to do a clinical assessment. We're going to ask the duration, the distribution, the itch intensity. We're going to ask them about their scratch, pick, and rubbing behavior, but you should do a full skin exam. I always look in everyone's mouth. I look in the genital area. You want to also ask them if they're having fevers, chills, vomiting for systemic disease. And then just baseline labs are more important, not for diagnosing PN, but for diagnosing the comorbidities of PN. So you should always do a complete blood count. You look at eosinophils. You want to check their kidney and renal function. You want to see if they have diabetes, see if they have thyroid disease. It can also be associated with HIV, hepatitis B and C. And you also want to make sure they're up to date with age-appropriate cancer screenings, because this can also be associated. And step 3, if the diagnosis is uncertain, you could do a biopsy as well. So we already heard about this a bit, so I won't belabor this point as well, but how do we measure the severity of PN? We have validated tools. So we use the PEAK pruritus NRS, which is 0 to 10. We ask a patient in the last 24 hours on a scale of 0 to 10, how severe was your itch, and greater than 7 is equal to severe. We also have tools that look at sleep, that look at quality of life, and that also look at depression and mental health. Okay, and this is just an example of the IGA score, and you can see like 0 in A is a patient with no nodules, 1 in B is someone who's almost clear. In C, this patient has moderate with still multiple nodules, and 4 is severe. But this just also helps us see like how severe is their PN, how aggressive do we need to be with the treatment, and also how are they responding to the treatment. So the comorbidity web, so as I said, PN is associated with many comorbidities. Specifically atopic dermatitis, there's an odds ratio of 5.74, asthma, allergic rhinitis, also metabolic comorbidities like diabetes, renal disease, 1.41. It's also associated with heart disease, infections. There was like a population from Hopkins where they saw that in like African Black patients, there was an odds ratio of 10.5 that they had HIV compared to the AD controls. It's significantly associated with psychiatric conditions, which I'll go through in the next slide, and also thyroid disease and malignancy. So these stats are staggering. 37% of patients with prurigo nodularis have anxiety, 29% have depression, and nearly 1 in 5 report suicidal ideation. So this is really a call that we need to be recognizing this earlier so that we can help these patients get the care they need. And you should, as a clinician, you should ask every patient about their mental health and their psychiatric health so that if they do need help, you're able to refer them to the right people and make sure they have those resources. And this was also touched upon earlier, but there's significant racial disparities and health inequity related to prurigo nodularis. African American patients are 3.4 times more likely to be diagnosed versus white patients. And then they're 10.5 times more likely to have comorbid HIV versus race-matched AD controls. The lesions are also much more fibrotic, as you could see in this bottom panel. And they're more hyperpigmented, and they're also frequently misdiagnosed as just like post-inflammatory changes. So this leads to that diagnostic delay, and it's really important to recognize this. So I'll leave you with a clinical framework for how we should approach patients with prurigo nodularis. We should recognize the firm nodules, the chronic itch, and the scratch signs. We should assess using the severity scales that I touched upon, and then it's really important to screen for all of these comorbidities. So some key takeaways: prurigo nodularis are nodules, itch for greater than or equal to 6 weeks, and scratch cycle, and it is its own disease. There's a 4.5-year diagnostic delay, so we need to close this gap by recognizing it earlier, by using validated tools to look at its severity and to screen the comorbidity web, and always ask all your patients about suicidal ideation as well. Thank you so much for including me today. I'm very happy to be here and happy to answer any questions if anyone has.
Thank you. We'll have later on discussion. Our next speaker is Diego da Silva. Diego is a dermatologist who's interested in itch, does a lot of clinical trials, and is working also in East Virginia in Frontiers Dermatology. Diego?
Thank you so much for having me, Dr. Silverman. I'm honored to be here and to talk about prurigo nodularis, one of my passions, particularly treating itch in general, but this is a debilitating condition, as was said earlier, one of the itchiest condition that you can have in dermatology, and it's something we want to raise awareness for and help with. As was said, I'm an assistant professor at the Eastern Virginia Medical School, also attending dermatology at Forefront Dermatology in a private practice, and I run a pruritus clinic and do clinical trials. So I'm going to be talking about prurigo nodularis currently, right now in 2026. What are the treatments that have been used, can be used, and as well as what's FDA approved. All right, some of my disclosures here in terms of who I investigate and consult or speak for, and where I'm a board member. And then briefly, before we get into the treatments, right, I'd like to talk a little bit about itch in human history, because this is something that's been well conserved and spoken about throughout humanity, really. There are writings or references from ancient Greece, biblical plagues, medieval times, more modernly in Africa, Asia, Latin America, certain tribes that are still around today who have either spoken about itch and its emphasis and its pain and suffering, or even used it as forms of capital punishment, in lieu of prison time or other, punishments we've had throughout history, where caustic or protogenic substances could be rubbed on people to make them feel really itchy, and then either trap them in a room or something like that. And this was seen as even more severe form of punishment, or even more reforming than traditional jail time and that sort of thing. So it's really interesting. This is a depiction from Dante's Inferno, which is a book from the medieval ages, Renaissance time, 1500s, where there are 9 circles of hell, and essentially the 8th circle of hell, one of the worst, the one before the worst, was a state of chronic itching, constant itching that could not be alleviated, right? And that was reserved for liars. And so this is a depiction basically of people who were accused or convicted of lying and who would have to spend eternity itching, right? And it's just a bit of a reminder, right, and how important itch has been throughout humanity. This is a quote that I really like from Dr. Fitzpatrick, a very prominent dermatologist, who talked about how medicine has traditionally been most concerned with diseases and disorders that end life, and we have to pay greater attention at those medical conditions that ruin life without ending it, right? In some ways, could be viewed as worse. And this is a little bit of a recap of certain things in human history with itch. One of the brief things I'll mention is, of course, been a long time, right? As early as perhaps the 5th century BC, that Hippocrates may have described atopic dermatitis, right? Different texts here, different philosophers and writers and gatherers of human history over the years have brought it up. I'd like to also bring up the fact that at one point itch was considered to be a mild form of pain, which I think is kind of interesting, because both of those can have deep impacts on human life in terms of the suffering and quality of life impairment, right? And itch and pain signals kind of travel along the same nerve track, so it's kind of interesting how these things play together, right? But along those lines, I think maybe not long term, right, but more recently, over the last, let's say, 100 years, itch has been viewed as what this says, like more mild or not as much of a big deal. When you actually do quality of life research, though, they play very equivalent roles in terms of destroying quality of life, and some studies even show chronic itch being worse than chronic pain, right? So that kind of goes against what was considered as mild, right? And then more recently, right, 2013, we had JAK inhibitors in dogs, and an IL-31 inhibitor, which is what we have in nemolizumab now for prurigo nodularis, is something that they had in dogs in 2016, right? So it's kind of the way treatments have evolved over the years, and just from things being described and kind of crude treatments all the way to the modern age with small molecules and biologics. We talked earlier today, of course, about what prurigo nodularis looks like and how to diagnose it, right? So I won't belabor this too much, but just to show some more photos, different things that it can be associated with. The highest risk demographic, which tends to be older, African Americans, although it could be any age, any race, can be affected. And then beyond the miserable itch, which we're certainly focusing on today, right, that post-inflammatory hyperpigmentation or hypopigmentation and scarring can be prominent features and can be a huge deal for patients, right? I think in general, itch is certainly, the most worrisome and the most bothersome symptoms, but once we can improve that with wonderful treatments, right, like our patient said today, depending on kind of what's left behind, the aftermath can play a deep impact on a patient's psyche and the quality of life thereafter. And it's the most interesting kind of overlap, I would say, between the neuroimmune pathways, right? Both neurology and immunodermatology playing a role. This is some of the non-steroid off-label treatments, right? I'll briefly mention the only on-label treatments right now for atopic dermatitis are nemolizumab and dupilumab. But historically and even actively, we will use many things that are appropriated from other conditions, even outside of dermatology, but within dermatology, from eczema typically. So these are a bunch of different creams and topicals that can be used. One of the ones you see there is something compounded, right, where you can take these medicines that kind of alleviate itch on the nervous system, and you can make a cream compounded out of it and then apply those to lesions. You can use gabapentin, which is a medicine a lot of people are probably more familiar with for nerve pain, but it kind of goes with that concept that we were mentioning, where pain and itch travel along these similar nerve pathways, and so sometimes that can help. But nothing's perfect, right? I think, a lesson that we learn early on in medical training is that if you see many treatments for one condition, that means that no one treatment works perfectly, right? But fortunately, there are folks now who care a lot about this from a basic science and research perspective, as well as investment into therapeutics and raising awareness. These are all the different systemics that can be used off-label, right? So again, not for anybody to memorize, but a lot of these, fall into a few different categories, which are traditional immunosuppressants, higher risk and perhaps not higher reward. So a reason we try not to use them anymore. Dupilumab and nemolizumab are on there as the FDA-approved ones, but then there's a lot of these neuroleptic medications like gabapentinoids and like antidepressants and tricyclics, as well as medical marijuana derivatives. So and other opioid modulators that are typically used for pain. So it's you can attack this from a variety of different ways, I guess is what I'm trying to say. And then we'll focus on what's actually approved now, right? So this is just a trial design, not to anything to be memorized or anything like that, but just showing how these things are studied, right? So this is specifically looking at dupilumab, where they screen people to have moderate to severe prurigo nodularis, at least 20 nodules on the body. The average itch in these studies can be anywhere 8 and higher. And 7 or higher is considered severe. So these are patients who are really suffering. And what I like to point out, especially when I do teaching, but in general, right, is that we arbitrarily decide this as kind of a medical community because you have to have like set parameters, right? Like what patients are we going to include in our trials? But the reality is there can be many patients who don't exactly have 20 nodules or who itch is not exactly at 8, who are suffering significantly, right? And so we need to be inclusive of those patients, at least in practice, even if we can't put them in a trial, to be able to treat these people. And it's really the impact that it's having on the quality of life is more important than the way the skin looks or what exactly the patient's history is outside of that. And then of course, typically you want to study a medication against a placebo to have an idea, which, that the medication is actually working better than the placebo, and also to have an idea of, any side effects that occur. Are you seeing, because, things that are recorded in a clinical trial, you may see certain side effects, but they happen to people in the placebo group and people getting a medication, because in life things can happen and you want to be able to know what's associated or not. So this is just some of the demographics from those trials there that I already spoke about. Patients itch being about 8.5 out of 10. Many patients with over 20 nodules, even but a good third or more with over 100 nodules. So really suffering patients. Many patients had a history of atopic dermatitis or eczema, but many of them did not, or most of them did not. Why that's useful, right? Is because when these medicines that are previously approved for eczema then get approved for prurigo nodularis, you want to make sure that it's not only working for the PN because it also works for eczema. And maybe these patients have eczema, it even works for prurigo nodularis in the absence of eczema as well. And this is just more on that. So the second piece to mention, right, is that eczema is not the only atopic condition or allergic condition that can travel with prurigo nodularis, right? There can also be allergic rhinitis, like seasonal allergies, asthma, food allergies, and these things can travel together, although you don't have to have all of them, but it's important to note that people can. And this is some of the difference, right? In the dotted, neutral gray lines you're seeing towards the bottom are the placebo groups, and the green, lighter green and darker green that you're seeing at the top is the medication. And from an early time point, as early as 2 to 4 weeks, you're already seeing a difference, right? Those curves, the placebo is improving actually, right? And I always like to mention, from my perspective, in my opinion, a lot of, not a lot of itching, well, everything the body perceives, right? It's kind of like mind-body connection. I think traditionally in Western medicine, we used to look at this as kind of like silly, right? Like, oh, this whole mind-body connection and stress and anxiety and like, how does this really play in? There's like biological mechanisms, like by itself it's just science, right? But these things all play in together, right? And so if you feel like you have hope, right? Our patient earlier today said, just even being in the trial, knowing that they could be in placebo, gave them hope, right? People will have some degree of improvement, but of course you want the medication to be much more improvement than just what hope alone can give you, and that's what something like this shows you. This is just another endpoint here. So specifically, instead of looking at itching, looking at the reduction of nodules, because you want the itch to go away, but you want the skin to heal as well. And then these are the patients getting both itch and nodule clearance, right? And so over time, you're seeing more and more improvement. 24 weeks, by the way, is like the endpoint for this study, right? And in any study, we have to pick an endpoint, but these diseases tend to be lifelong diseases, and we really want to, hope that the patients continue to get better over time. So some pearls on dupilumab. Again, it works for a variety of other things, right? You see in the literature off-label, but approval for many things. Perhaps the least well for pure neuropathic itching outside of prurigo nodularis, but still has worked for a lot of my patients. Some people get better really fast, right? 1 or 2 injections, they're a whole lot better, and people out there may have had that experience. Other times it's 3 or 4 months and it's starting to hit its stride. So it's just kind of to provide that hope for the patient so they don't feel like 1 or 2 months in they should give up on their treatment. And some people do better on weekly dosing than every other week, but it is approved every other week. Safety-wise, patients always want to know this, right? We want to balance how they feel and how much better they can get with creating another problem. I think in medicine, we're often very guilty of that, or just as something that happens where you fix one thing to create something else, right? And I think that's okay. We come into it knowing that as physicians, we want to do the best for our patients, but you want to make sure you're not trading it for something potentially worse, right? And the side effect profile is quite good for dupilumab with the main things we're looking out for, a little conjunctivitis or eye irritation that some people can get that can be treated with artificial tears and other agents to help with that. And then a few different features here that it not being an immunosuppressant means it can be used in people with a history of infections or who have infections, and people with a history of cancer who have cancer, even people who have HIV. It's not necessarily studied in these populations, but we have a variety of evidence sources, and after the medications are approved, where people end up on the medicines and then they're followed over time, what they call post-marketing surveillance. So a lot of safety actually goes into medication management after a medicine's already approved by the FDA. So same goes for pregnancy here and lactation. This can be combined with that long list of medicines that I showed earlier. So you don't have to use this alone, although for many patients it does work alone by itself. And in terms of managing those side effects, I briefly did mention that it's not super common, but when it does happen, artificial tears, antihistamines, these kind of fancier eye drops that eye doctors will typically give, but essentially it's very uncommon in my experience that I've had a patient doing great who's had to stop the medicine because of these eye issues. And then these are a host of other very rare side effects, right, just to be completely transparent with any patients we should, that have been either reported or are out there in the literature. And so some people can get psoriasis or other skin diseases. Some people can say that their joints hurt or that they've lost some hair or that they get some flushing. All these like random things that, I think some people might view a list like this or any list, right, when you go on Google or one of these ChatGPT, these things that people use these days, and they might say, I don't want to develop any of these things. But I think life is all about a calculated risk, right? There's a risk even when we get our car and we drive that we might get into an accident or something bad might happen when we fly, when we do anything. So, I think we want to have an idea that certain risks, especially ones that we want to avoid, are very low and unlikely to happen compared to just things that happen in life. This is nemolizumab, so I won't belabor this too much. It's very similar trial design and sort of like in terms of using the medication versus a placebo and studying it over time. In this scenario, they weren't allowed to use topicals in the background versus in the dupilumab studies, they were allowed to continue their topicals. But at the end of the day, it's still, that's the case in the placebo group or the medication group. So not a big difference between the two trials. The patients were doing very poorly, right, with that itch of 8.5 out of 10. Many of them had over 100 nodules. This is just demographics, probably too small for anybody looking at home to be able to read, but patients of a variety of types, right, of backgrounds and creeds and races and ages and backgrounds of anxiety and depression and different medications that they tried and whether or not they had eczema in the past. So just not to study a very narrow population is something we want to see. And the light blue line here versus the gray is the difference, right? You want to see a big difference in those charts between the medication and what placebo is doing, right? And so on the left is the itch response, on the right is the skin clearance. And then here specifically looking over time, right, as early as 1 to 2 days, you're seeing a difference in terms of the people getting an itch response or sleeping better, which is what's on the right, compared to those on placebo only, although both are, perhaps slightly improving because of that hope and placebo effect. Nearly 9 out of 10 people have this itch response at 52 weeks in the long-term study for nemolizumab for prurigo nodularis. About 14% have it at 48 hours. And this is a novel mechanism, so sometimes people get worried about things that are newer. I use that in air quotes, like IL-31 blockade, but that's why I brought up in the beginning, like this is a mechanism that's been known for a long time. It just took us a while to develop it in humans, and even the veterinarians had access to it before we did. And one of the unique things about this medication is it doesn't need to be refrigerated for 90 days, and it's kind of mixed up in real time with the instructions there. So some people find that convenience in terms of being able to travel with it, etc. I treat a lot of military members where I live, and that's something easy for when they're deployed and such, or college students or other people. This is just, these medications are not studied against each other, so let's be fair in saying that, right? There's not a specific trial that was designed to say one is better than the other. But I like graphs like this when you can control for the placebo response and then put the two drugs on a graph and say, like, what are the differences between the two if you were to pretend they were being studied head to head, right? And it's like at the beginning you might see different pros. So this specifically looking for itch response, you might say nemolizumab's a lot better than dupilumab early on, right? But then you go out further out and these curves touch essentially, right? They get very similar. So it's not like your clinician can pick the wrong treatment for you. I think both are excellent treatments, right? It just kind of depends on preferences and other comorbidities people might have. This is specifically looking at the skin clearance. These lines are closer together and they start really close and they end really close, right? And like maybe in the middle there's a small difference, but again, not a large enough difference to where, in my opinion, I say every patient with PN should be put on one specific treatment. Some of the side effects can be a little bit different, so you don't really see the conjunctivitis or eye irritation with the nemolizumab, but you can still occasionally see some joint pains, some hives and other things that can come up with some people. This one tends not to hurt as much, but it does have this potential side effect of causing some eczema flaring, and even in patients who never had eczema to begin with in the trial. So these are just things that we keep in mind when we prescribe to patients. This is just a representation. So essentially, the whole gist of this talk and of this day, right, is don't underestimate itching. Itching is very crucial, very suffering-inducing to our patients, and I think historically underappreciated in medicine. And again, we focus on things that can kill people, and while itching may not kill people, it has made people, as we spoke about earlier, feel suicidal or want to end their own lives. And many people would argue that it's much more miserable than being alive. And so I challenge all of us, and especially us here, care a lot about this, and I think all of us in medicine care, but we should encourage patients to advocate for themselves and the whole medical community to be more aware and essentially push awareness and treatment and follow up on so that patients can actually know that we care and that we're here for them. Okay, so this is my family, and thank you all for listening.
Thank you.
Thank you.
There you go. So I will have a last talk of the day, and I'll discuss a bit the future. The future of emerging therapies and biomarkers for prurigo nodularis. And I think just to sum up, we had today a discussion that this prurigo nodularis is a disease where there is a itch and scratch cycle. The intense itch triggers scratching, and it causes more nodules, and then it's very difficult to treat it. And we've had the discussion also on the pathophysiology, understanding that there is a interaction between nerves and immune cells. And we had quite an understanding that there is a quite significant numbers. In fact, the numbers of patients have grown significantly, and I think that one of the explanations is that for so many years these patients would not show up anymore to derms because derms didn't really provide them with good treatments. And now that there are better treatments, there's more awareness that we could have treatments for these patients, and we see more patients. Oh. Okay, sorry. Oh. It's not going. Oh, okay. And one of the issues is why it is difficult to treat these patients is that, as we discussed a bit, the pathophysiology, there are cytokines, there are nerve fibers that are very sensitive, and there is a activation of the nerves that are oversensitive. So there are multiple pathways to induce the itch, and this is where there is a challenge. This is a very complicated figure, but it kind of describes all the targets for treatments of prurigo nodularis. And I have to mention that we have treated already, we have discussed today targeting type 2 inflammation, but there's a significant component here of nerve sensitization, and clearly there are other targets, and I'll discuss some of them that are future targets that are undergoing treatments of advanced treatments now. So one of the issues first is, can we identify biomarkers, and the question is, what is a biomarker, I think. But first of all, we have to understand that this, it's a measurable signal or in the blood, skin, or body that tells doctor what is driving a disease of a patient and can enable us to better understand what treatment is most likely to help the patient. And this is where we're facing in medicine now, is to try to, what we have is a personalized care. These are why all these genetic studies are done. And then the question is, can we track the disease activity by using biomarkers? And then, can we really predict the treatment response based on these biomarkers? I'm going backwards. So I'll discuss a bit some of the biomarkers. I have to mention that none of them are ideal. So we discussed already today that interleukin 31, which is a type 2 cytokine, and nemolizumab targets it, and this is called the itchy cytokine. I have to mention that for many years, we, as our group and other groups, have tried to measure IL-31, and the measurements were incorrect. The antibody, or the measurement that was available in the market, was not really measuring most probably IL-31. But I have a good message here, is that recently they have developed a kit that measures the levels of IL-31 accurately, and it does reflect that it is related to prurigo nodularis level of severity. Another option of targeting or measuring a biomarker is the level of IgE. This high IgE levels in some cases have been elevated in prurigo nodularis. These are patients where there is a component of allergic disease. Other options of targeting or measuring biomarkers is a marker of activating the nerves. Proteases are activating the non-histaminergic nerve fibers called PAR2, and it's a mast cell marker tryptase, and it's released by mast cells. Dr. Natkemper nicely showed that mast cells are activated, and this could be also been tested in drug trials of barzolvolimab, which is a drug targeting the mast cell. Other options of looking at biomarkers are a ligand, or it's a mediator that activates the IL-31 receptor. Oncostatin M is a part of this receptor, and it is sensitizes of nerve, also of another type 2 chemokine called TSLP is associated with activation of the nerve fiber cycle. And our group has also found that another neuropeptide that is secreted by nerve fibers is actually associated with prurigo nodularis. This is something that those of you who suffer from congestive heart failure, God forbid, but those who have heart disease, brain natriuretic peptide has been found to be elevated in patients with prurigo skin and in the blood. And our group showed nicely that it is correlating with different types of chronic itch. It's not just with prurigo nodularis, but it is associated and highly associated with patients with prurigo. Oops. It's stuck here. Oh. Okay, I'll try to get... I'm going backwards. Okay, now, okay, so now we have already, Dr. De Silva nicely discussed the two drugs available, dupilumab and nemolizumab, and now when we're discussing what are other future medications, I'll share with you the exciting aspects of new drugs. There are several drugs that target the immune cells. There are what we call small molecules, JAK1 and JAK2. They are targeting the immune system. There are drugs that are targeting the oncostatin M that I mentioned as a biomarker. And then there's a drug targeting mast cell, the c-KIT. So I'll start with the first. Clearly, because of aspects of so many immune mechanisms involved, broad suppression of the immune system can have an effect on reducing prurigo nodularis. However, using these type of medications, you cause significant side effects. But nowadays, drugs that can target like small molecules such as JAK1 or JAK2, they are safer and target not just one or two cytokines. So we'll start maybe with the drug that is targeting the mast cell. Barzolvolimab is a drug that is targeting and kind of depleting the mast cell that Dr. Natkemper nicely, as I mentioned, showed is involved also in the itch of PN. This drug blocks a receptor called c-KIT that mast cells need to survive. And what you can see here is that there is a significant dose response, that this drug clearly reduces. This was a phase 1 study that we were involved in, that just a single dose was leading to a very rapid and meaningful itch reduction. And I mentioned about the JAK-STAT, another study that is using a JAK-STAT inhibitor called povorcitinib, which blocks that pathway, has, again, once daily dose of an oral pill. This is a, in difference from the other drug trials, this is a oral medication, which sometimes patients prefer to have oral medications. Again, what you could see here on the figure is that there is a significant dose response and itch response. And again, this is a drug that is undergoing phase 3 trials. And another drug that, as I mentioned, targets of type 2 inflammation, targeting the OSM receptor, which is part of that receptor complex with IL-31, is vixarelimab. This is a monoclonal antibody that blocks the oncostatin M receptor, and again, it has a very rapid effect on itch, very similar to what has been shown with nemolizumab. These are, again, preliminary data from a phase 2 trial. Unfortunately, I don't know if this drug development will continue, but at least the pathway of targeting this OSM receptor is very promising. So what does this mean for patients? So clearly that it's exciting to see that there are developments beyond dupilumab and nemolizumab. What I think that is important to remember is that we're trying to better understand if we could use biomarkers. I think we're still not there, but if you, as a patient who suffers from PN, can ask nowadays in this era, almost every clinic I have, patients come with a list from ChatGPT or any other AI platform, and they ask, doctor, can you tell me XYZ? So if you look at that, at least ask these questions about whether there are, if it is worth to measure IL-31, IgE, BNP, and tryptase. The answer at the moment is that we don't have yet something definitive, but there is a possibility that we'll have these biomarkers. Remember that if there are unfortunately still cases of prurigo nodularis that do not respond to the excellent medications that we have, unfortunately none of these medications have a 100% efficacy. But there are undergoing clinical trials, and I do recommend that if you fail those two drugs, at least it's worth to try the povorcitinib or barzolvolimab. Hopefully these drugs will be in the market. Again, these drugs may target different aspects of the disease and have a potential for those patients who do not respond to the other drugs. My message here is that there's extensive research. I can tell you that still drug companies are interested in developing new options of treatment for chronic itch and PN. And I strongly believe that there'll be other developments in the field. As you saw, it's a very complex disease. So I'd like to thank you, and I think that we can open our discussion and for questions, and hopefully you enjoyed learning about this disease and the experiences that we shared with you, and in particularly I want to thank the patients again for sharing their stories. So I think that there are some questions here. Yes, I'd like to thank here, we have in the audience two major folks that have a significant impact on the world of itch. I'm sorry that I'll have to mention your names. One of them is Andy Bolveld. He's well known. He's a immunodermatologist who has done so many clinical trials in the field. So I'm more than happy to see you here. And next to him is sitting here is Maria Turner. Maria is one of the best clinicians that our profession has. I've known her for so many years. She was at the NIH, and love to hear your thoughts and maybe your comment. Andy?
So I'm curious about the onset of the disease. So we had one patient who seemed to be just fine one day, and then one day she wasn't. And then the other patient, history of eczema, itching, and then developed. Is PN usually, is there a day where patients can pick when they started it, or does it tend to be insidious, or is there all types? But it sounded like both of them kind of identified, I thought was unusual, was this just one day they didn't have it and then they had it, which suggests an event, right? That maybe was it, can you?
This is an excellent question, Andy. I have to admit that, let's ask first the patients. It showed up as a small lesion, or how did it show up? Can you elaborate? And then I'll say what I see, and we're biased because they come to us after usually they see other doctors in the the community. So maybe you would like to comment.
I never knew if the spots came first or the scratching, but I think it was the scratching. And like I said, I did have a history of itchy skin. I had sun poisoning that I would get. I had noceums that attacked me and was itching. But this was just, I can't remember when it started, but, just gradually over a few days, a week or two, it's like, oh, this is suddenly very bad. And then just proceeded to get worse.
Cheyenne?
Right. I would also say, I remember the span of the month it happened, which is I said, it was a lot of change that was happening too. And it was when I was just graduating high school, and I remember it was during my freshman year of college. But I remember it was just a one specific month. I don't even know the month, but I just remember it at some point it was like she said also, it was the scratching that was this is not normal. This is not a normal eczema episode. And then that's when probably I saw a black mark, and I was this is not eczema still. So, yeah.
So, it's excellent. I think what they're telling us is very similar to what I believe in, that this is the itch, that it's the rash that itches, it's the itch that causes rashes rather than the rash that causes itch. And that's a bit different from atopic eczema, but in PN, there are two aspects. There are PN patients, and I have to mention in the atopic eczema population in African Americans, it goes together sometimes that it's the presentation that is associated with inflammation, but I see PN as a trigger of itching that activates fibroblasts. So it's secondary in a way to the scratching, as they kind of tell you, but I'm quite sure that in those who have atopic eczema, it's a bit different. My colleagues in Germany, I have to mention, feel that there is kind of a progression. It starts as a papule, and then it's kind of a progression from a papule, even a lichenified plaque, and then it becomes a prurigo nodule. But clearly not everyone with eczema develops a prurigo nodularis. So there's something unique in the scratching that activates the fibroblasts to secrete some mediators. I didn't mention that, but our group has looked at periostein, which is secreted by fibroblasts and is highly associated with prurigo nodularis. I should have mentioned it in my lecture, and it kind of amplifies the itch stress cycle. It does also have an activity. This is what's unique in periostein. We thought that it only activates the immune system, but apparently periostein could activate the nerve directly by activating the integrin alpha beta receptor on the nerve. So there's something unique here with the mechanism of PN. Hopefully that answers your question, but I think there needs to be more kind of research on that. I see that there are some questions. I'll try to. Okay, Maria, please, and then we'll answer.
Yes, just some general observations. I'm pleased to be here at the meeting. Itching has always been primary in my mind because I don't think you can be a dermatologist and not be an expert in itching. There's no reason for that. And I was at the NIH for the last 30 years of my career, and I was always pushing research on itching, research on itching. You've got to do it. So for the patients themselves, I have several things to tell you. If you have had itching for more than 6 weeks, definitely consult a dermatologist. Absolutely. And then for the dermatologist, once you see the dermatologist, that dermatologists should really take a complete history, because your itching can be caused by systemic things like liver disease and kidney disease and lymphomas. And so you need somebody who knows that. So you go to a dermatologist, you have lesions, you have to do a biopsy. Not a biopsy, several biopsies. You have to biopsy an early lesion, you really have to undress the patient, look every place, biopsy an early lesion, a medium lesion, anything that looks different. You may have to take 5 biopsies. And you have to have a good dermatopathologist and a neuropathologist. And there's a very good one, Dr. MacArthur at Johns Hopkins. I used to work with him. So those are the things I have to tell the patients. And by the time they get to me, they've tried all the antihistamines and nothing has worked. So that's a clue. Histamine is not the major thing. You may find it there, it may be a biomarker, but it's not the major thing. It's a side thing. And so I think we have to go to the biologics and really measure biologic markers. I think we will get there eventually. I can tell you that I worked a lot with chronic liver disease, biliary cirrhosis. And that was an opioid problem with opioid receptors. Nothing else worked. So it's a completely different bag of itching. And I saw a lot of mast cell patients. They itch some, not a lot. There's a lot of fibrosis. That's another bag. And so I just mentioned those two. I could go on and on, but I won't. I have a suggestion, and maybe it's pie in the sky, and I'm not an expert. I think we have AI here, and I keep telling Andy about AI, and I don't know much about AI, but I said they are now using AI or more sophisticated types of AI to put all the biologic markers, all the histopathology, all the courses that the patients have had, and maybe will come with some direction in which to head. It's not, I think you can diagnose scabies when you see it. You can, those are not the major things. The major things are what our patients have told us about. And sometimes you don't see anything on the skin. The case that was mentioned here, which was published in the Washington Post, mystery disease, brachioradial pruritus, no lesions. But the itching was driving the patient crazy, really. And happened to go to a dermatologist in Los Angeles and said, oh, that's brachioradial pruritus. So that's it, I'll stop.
No, I'm repeating because the crowd in the Zoom cannot hear. So Dr. Turner mentioned that it's important to assess these patients, and also that the complexity of itch of different types, and sometimes you need to do skin biopsies and not diminish the patient's complaint. Even if you don't see any lesions, you have to take it seriously in patients who have chronic itch of 6 weeks and more. Yes?
Sorry, I missed something I was going to say. The histopathology in prurigo nodularis is different from other itching lesions. The proliferation of nerve cells occurs in the dermis, not in the superficial area, which are different types of nerve fibers. That's another clue.
So what she mentioned is very important. The pathology in prurigo nodularis is very unique, that there's thickening on the dermis of nerve fibers. And by the way, not just in prurigo nodularis, in the epidermis, our group and others later on confirmed that the epidermis nerve fiber density is significantly lower in this condition and in general in pruritus. One of the world experts is sitting next to us because she is, I I'm not just overestimating her capability. Dr. Natkemper was a Mohs surgeon technician before she was a neuroscientist, and she has an invaluable understanding. You want to discuss a bit the nerves and?
Sure. So, humbly, I have become an expert in being able to stain nerves in the skin, and part of my research path has shown us that a lot of our itch conditions have a reduction in nerve fibers in that top layer of the skin, the epidermis. And this is something that was very surprising because one of our first publications, whenever my first days I tried to do, we found this and all the reviewers didn't believe us. And so we actually couldn't get the paper published, and Pemphigus foliaceus didn't believe us. So it took us, I think, another 7 years to show this in atopic dermatitis, that these nerves were reduced. And now we can show this in prurigo nodularis as well. So it's that reduction in nerve fibers and that sensitization that I showed about that's what's causing this activation. So you have that higher threshold. Those nerves are already overactive, not just because there's more of them, but just because they're overactive.
It's different depending on the layer.
Yes.
I have a question to the patients, to Cheyenne and Catherine. What are you expecting, or what was your disappointment from healthcare providers before you got to see, the experts? What's your message to healthcare providers in terms of your interactions about the disease? I noticed that everyone treated you for scabies, but
Yeah. So silly. I just feel like if you don't know, just say you don't know. Like if you truly don't know what it is, like, or you want to understand more about it, like keep me there, or like tell me to come for a next visit while you research on it, or just be honest. I feel like that's the most thing. Just be honest.
Yeah, we had similar experiences that so many doctors, scabies, bed bugs, allergies, never, went down to think any of this. My favorite was a younger doctor who looked like he was new to the field, very nice, but he started Googling pictures that looked like my spots. And I thought, well, yeah, I did that too. And then he said very nicely, he said he could ask his mother because she was a retired dermatologist. I thought, well, okay, maybe I'll call her. But yeah, just the lack of awareness of so many doctors about this.
There's a lot of research we need to do.
I don't see any questions from are there any questions out there, or maybe? Okay, maybe Dr. De Silva?
I just want to state to your point, that's one of the main things I bring up to trainees and even other doctors that are established who don't love treating itch or who don't see a lot of itch. That itch can be very complicated, right? We mentioned the unmet needs in terms of research that's necessary, the litany of medications that have been tried over the years, the misdiagnoses. And I think one of the most important things on that initial chronic itch visit, the important workup of labs, biopsies, et cetera, not telling someone, oh, this is nothing, just take an antihistamine and go away, but also stating that this might be a long process, right? That I'm not 100% sure, right? So that the patient doesn't think like, oh, they know for sure. We should be honest. Sometimes I think we don't want to turn off patients by making them see that human side of us, but we don't always know exactly what a patient has. And also telling them that there's going to be trial and error, right? You're going to try a few different things, and if they don't work, this is the follow-up plan, and I'm not going to give up. And if you don't give up, I won't give up. That's what I tell my chronic itch patients, and we'll keep working through this together, because if you don't say that from the get-go, that second or third thing that doesn't work well or something that doesn't go well, then that's it. They've given up on you, and hopefully they'll find someone better than the next go around, but it decreases that kind of confidence and faith in the healthcare system.
I have a question though.
Sure.
Wouldn't a biopsy, or maybe it wouldn't, would a biopsy show you what you're dealing with?
Not always, because it's kind of an imperfect science, like to what she was saying, right? Like if the pathologist is not super well versed in this type of staining or what they're looking for, or even if the dermatologist doesn't biopsy the right phase of a lesion, that's why she had mentioned, right, like the early, late, mid stage, there's just a lot of things that can be missed essentially. But you're right, in the ideal world, it would be like exact answer.
Thank you.
I would say that the biopsy, prurigo nodularis is a clinical diagnosis, and a pathologist can rule out conditions that are like hypertrophic lichen planus. By the way, sometimes there is like squamous cell carcinoma. There is a form of squamous cell carcinoma that actually is associated with prurigo, a keratoacanthoma-like. So it's important to know that, but I would say that a lot of times it's not the pathology of a clear diagnosis. So when a pathologist tells you, a lot of times they say lichen simplex chronicus. This is not lichen simplex chronicus. So the clinician has here a role. The pathology is helpful, but it's not the conclusive aspect of it. So I think that's important at this stage. So, yeah.
I forgot again. Excuse me. I think everybody will agree that prurigo nodularis, real prurigo nodularis as we know prurigo, is much more commonly seen in the darker skinned people, not just African Americans, Asians as well. And you're familiar with the back scratchers that they sell in China, so you can reach wherever you're at, you're itching. So that's another clue. Do the melanocytes have anything to do with it? We know that nerve cells do. We know that keratinocytes do. We know that fibroblasts do. Do the melanocytes have a role?
Okay, so this is like one of the exciting stuff that we're working on. So the question was, do melanocytes, because in skin of color, there's a significantly higher, more expression of a disease. So my answer to you is 100% you're right, Dr. Turner. Our group has been working on melanocytes and dendritic cells, and apparently there is a very strong connection. Melanocytes can actually activate dendritic cells. This is a study sponsored by Regeneron Sanofi. We're still learning that. It's interesting. We found some of the information and no journal wants to accept it because they don't believe us. Dr. Natkenberg can tell you that you got it. I'm just saying it just takes time, and I think that melanocytes, everyone says, well, African American, they don't go to the healthcare system, so their severity is related to chronicity of a disease. I'm telling you that's not the answer. The answer is a lot more complex, and part of it is melanocytes. So stay tuned, and hopefully someone will believe our data. We need to establish more of that. Lee, am I right?
Yeah, it's very interesting because not only are we seeing this in patients, we're also starting to be able to model it in animal models. So we're going to be able to have a preclinical model that we can also show this and use this for testing and for hopeful future treatment testing as well.
Granules in melanocytes have a lot of things in them.
Yes.
We have time. So back when I was in Miami, so I was in Miami 1989 to 1992 during the AIDS epidemic. And one of the things that we diagnosed all the time in the dermatology clinic was something we called PPE, the Priddick papillary eruption of AIDS. And there was AIDS patients who would have prurigo nodularis, basically extremities, and Neil Penny's at the time did staining for mosquito saliva allergens, and I think it published this that it was in AIDS patients' hypersensitivity to mosquito bites, basically, in these AIDS patients. So, is that still a thing? This hypersensitivity to mosquito allergens, and why would AIDS patients be susceptible to PN?
Because their immune systems are all
The
wrong.
T cell, yeah, I mean, this is correct. And so the question was that in HIV patients who were at the time also in African Americans, this immune system was overactivated post insect bite reactions. So I would say that at the moment, I don't see these cases so many anymore, although we've done a study when we were at Wake Forest on HIV and itch, and it's still the number one. Actually, nowadays, even with the all the drugs for HIV, and they're very good, but still now the skin symptom is the most common is itch, actually. So there is something in HIV inducing and its immune system. But to your question, what we now know, and it's a good example, is that in patients with B-cell lymphomas, they have a very similar papillary dermatitis. It's all activation of immune system. So from an insect bite reaction. So I think it's very similar here. I would say that nowadays we don't see any more prurigo nodularis in HIV. So I think that it is related to some kind of CD4 activation, but I can't really answer. We don't have that capability of I don't know any one of you sees these patients. We don't see any more HIV with
So a couple in
prurigo
residency
nodularis.
of
Yes.
people who are not controlled, like
Yeah.
who didn't know and
Right.
were on therapy, but you're right, the therapies are so good, you see less now.
Africa, I think it's-
Oh, you're right, fair.
Many
Yeah.
inpatient consults that were not controlled.
What I could say is that our group that we didn't, by the way, for scabies, we are very close to find the exact mechanism of itch. And it would be very interesting, but it's not related to prurigo today. But anyway, so that's the exciting part. And for mosquito bites or a lot of insect bite reactions, I think that there's a lot more to study. It's not just histaminergic. Everyone says give antihistamine and it solves everything. It's a lot more related to proteases that are secreted by mosquitoes, but that's for another session. Okay, let's go back to prurigo. Maybe Sufi, would you like to share what you've done some work on Asians or no?
There's actually a bit, Asians are the fastest growing demographic in the United States. And so there's a lot of attention. In fact, this is a plug, in another week, there's actually an Asian dermatology meeting up in New York. And a bunch of people who are very vested in skin issues related to Asians are going to get together to talk. One thing that is really important as we sort of tease out how all sorts of itching disorders, including prurigo nodularis, is to disaggregate the Asian data. So people tend to lump all Asians together, thinking that we're a homogeneous population, and that's a huge mistake because we've got many, many countries that are Southeast Asian and East Asians, and we are not the same. And so really paying attention to disaggregated data is really where the next step is going to be.
Good. We've done actually a study in Korea, because you mentioned in Korea, it's our former fellow, Dr. Kim, all of them almost are Kim, Hazel Kim, and we found on prurigo nodularis that it's very highly associated with markers of keratinocyte activation. And I have to tell you that this is interesting, that interleukin 22 is one of them, and there are a lot of interaction with neural components of this disease. So it's not just a type 2, it's easy to teach everyone that type 2 inflammation, type 2 is secondary and it's extremely important in itch, I'm not arguing, but there are other components that won't surprise us that if you target, it's possible to, in the future, target this disease. So hopefully we'll have to also learn in the next couple of years about the role of this mechanism, and it relates a lot to possibly scratching, because scratching is a big deal here in PM. And by the way, I want to mention something very important, is that a lot of my patients, and you mentioned that both of you, both Shaheen, but I think Catherine is also, you actually discussed that, is that many doctors, and I actually gave once a talk in front of dermatologists in New York, and one of the doctors says, Dr. Yosipovitch, why didn't you tell us the best way to treat patients who have chronic itch with prurigo is to tell them to stop scratching.
Oh, gosh.
And I looked at him and I said, do you stop yawning when my lecture is not so interesting? And he looked at me, yeah. So I mean, I'm just saying this is ridiculous to blame, to tell the patient to stop scratching, because you can't do that. So I'm just saying that unfortunately it's still common in some types of maybe old school, and hopefully these type of meetings enlighten us from your perspective that we should not blame you to stop scratching.
Like telling patients in pain, just stop hurting.
Right, correct. Okay, I think that I'd like to finish this wonderful event, and I want to thank again, I don't think that the pharma is here, but our sponsor, there's someone there, the pharma that supported this event with their gracious support of this event. It's Regeneron, Sanofi, and Galderma for supporting not just this event, but advancing. These are diseases, I'm sorry to say, they are not like atopic eczema where you have millions of patients, but the fact that the companies were willing to support research in the field enabled us to do these drug trials and eventually to develop these drugs for our patients. So I thank you again, not just for the event, but overall for advancing our science. So thank you all of you for participating, and later on this is recorded also so people could hear and listen again. Thank you, all of you too.
Thank you.